Dear ladies and gentlemen, welcome to another session of Let's Talk. Today we are going to talk about immediate placement and immediate loading. We have two guests here in the studio. My first guest is Ueli Grunder, and you have a private practice in Zollikan, Zurich. Welcome to the studio, Ueli.
Welcome.
Another guest is Marco Degidi, and you run a private practice in Bologna. Is that correct? In Italy, yes.
Great.
Welcome to the studio, you both.
Thank you.
And you both published extensively in peer-reviewed journals. So, can I call you scientists or not?
No.
No.
No. For my publication, scientist is a very high word. I publish mainly case reports, which has nothing else to say than that I look at my cases. Maybe you do the similar, you're correct. I will look at the cases and then we describe what we see every day. So we describe our clinical work, which is, if I may say so, more value than any so-called scientist paper, many scientists paper, because we write what we know that it works. And if the scientists do it, and I like to say that, they have a small number of cases, and then they find out that whether they have a p-value, but that is not helpful for a clinician at all. So yes, we publish, but I personally mainly publish my internal evidence, let's say it like this, so what I see every day and what I know, it works.
Okay.
What do you think?
And what about you?
What about your publication?
Case-based
Are you a scientist?
research, is that science for you?
Well, I think it's little science. I mean, I totally agree with Ueli. And basically, we are not scientists, we are reporters. We report what we see, okay? And so we spend time. We take time from our private life, and we spend a lot of time observing what's happening in the office every day, collecting data and cases, and then, when you have some free time, instead going skiing or whatever, we start writing articles in paper. It is very important that private practitioners take the time to collect and share their own experience, because this is how the community honestly, without bias, grows, okay? And it is very important. If we understand that we can really learn and advance by mutually sharing our experience and our achievement, that is a step forward. So this is what we are.
Yeah, but
Okay.
I like the comment that you said that we published a lot, because I think this is really, we look at our cases and then we report it. And
Exactly. And
the report is not so important. What Marco actually said, to look at the cases and to record what we do. And I always learn. If I look at my cases, I follow up my cases, I learn most.
Yeah.
And then we can go and teach what we see, what works, and also what doesn't work. So yeah.
then the community learns, which is also important.
Yeah.
So when we are talking about this immediate placing and immediate loading, science is also important to know when you apply this method. Marco, in your practice, a lot of patients receive these new implants in one visit, as I understood from your presentation. Is that correct?
Well, let's say that immediate loading is just one way to restore compromise situation, okay? And sometimes it's the most predictable, and sometimes it's the most risky. So you have to do a good screening and select the proper case. Then it is true that in my practice, I get so many patients and referrals just because they know that I'm good in this. So I do probably more immediate loading than Ueli does, because the people come to see me just because they want this particular kind of treatment plan. Okay, but sometimes, even me, I have to do a step backward and say, you know what? In your particular case, a stage approach is better. In other case, people come and say, you know what? They want to take everything out, they want to put a denture, I don't want to have a denture, and then I say, you know what? We can do everything in one step, and you will be happy and in a predictable way. So it's all about selecting the cases and have some, how can I say, instruments, some skillness to do this treatment plan, because they are not so easy.
What is so interesting about what you just said is that you say, okay, I'm super experienced, I'm very good in my job, that's why I can do the, yeah, that's what you said. So that's the reason I can do this immediate loading. So you have to be a super experienced clinician in order to be able to do this.
No, I think every technique has a learning curve stage or immediate doesn't really make a difference.
Okay,
On
that's
the contrary,
for all methods.
it is commonly and mistakenly perceived today that immediate is easier. So you don't need any training. On
it's
the
not
contrary,
specially for this method.
It is not. This is not the case. I think every approach is really pretty much dependent from your particular skillness and from the difficulty of the case that really change from 0 to 100. So once again,
it totally
it's all about
depends on
selection.
the case. Do
Yes.
you agree?
But he is a very talented dentist.
Oh.
I want to say that.
Yeah, but this is not
You know,
the point.
If you
Otherwise,
look at the lectures, and we both see a lot of different lectures, you can judge. He is a very talented dentist.
Okay,
Well,
now
that's a big
thanks for the
compliment, thank you.
confirmation. Now, scientifically proven you are a good clinician. No, but Ueli, do you agree this is totally dependent on the case,
Yeah.
whether you apply this immediate loading, or is it dependent on something else?
No, it's dependent on the case, but it was interesting actually that also the praxis, you know, you have a certain amount of patient. So most of the patients are referred to me. They are asking for the best possible aesthetics because I'm known for that. He does aesthetic cases as well, but if the people know that there's a dentist where I can go and I don't have to wear a removal at all, then they choose him. And as he said, Marco, during his lecture, that was very nice. You know, not every case has to be perfect. Some patients, they're happy with a small compromise. It's the demand of the cases that has a big impact of what treatment plan we have for each individual situation. So let's say the immediate implant, we have cases, and you have shown some of them, where you can say, well, you will not get the perfect result with immediate, but it will be acceptable. And if the patient doesn't show up or it's not his main concern, it's the perfect way to do. On the other hand, if we have patients, they come for me, especially because the dentist referred them to me, telling if you go to Grunder, you will have a perfect result. Sometimes we can't even offer it because we have limitations. So it really depends not only on the indication from the patient, but on the demands of the patient. That is a big impact.
Wow. So you're not always choosing what's medically seen the best solution, but also what the patient wants.
You know, for good luck, they forget it now, but there in the around 2000s, everybody started to talk about evidence-based decision making.
Exactly.
Such a stupid thing, as we would have not done the same thing before, but this was a new wording. What did you do in the 80s? Evidence-based decision making, but nobody called it like this. But in the glossary officially, it's written three components. Mm-hmm. Unfortunately, they start with the scientific evidence, which should be the last by far. Yeah.
Wow.
First comes the patient.
Oh.
And it's written, and in the glossary written, it's the patient's demand and the patient. Then comes the experienced. That's number 2. And then we back up with scientific data. And if we don't have the experience to look at the case, you can't find this in any study. Case selection you can't find in a study. This is the experience. So these 3 pillars, actually the last one is the scientific backup. This is evidence-based decision making. nowadays, maybe if you travel around, you realize that even the people from the university said, well, maybe scientific evidence is less important than clinical experience. That's the new knowledge they find out now, and this is good news.
We could discuss that.
Well, I think I agree, although we are working on thin ice here, and it's sometimes not so easy to say that. But yeah, I definitely agree. But as expert clinician, I think we have some responsibility toward the other colleagues, the young generation, the less young generation that want to basically, that need some guidelines.
Exactly.
So the attempt that I made in my last decades has been to to try to find some common point that I can put together, kind of guideline that I tell to everyone and say, look, in this situation, with this particular material or this particular hardware, if you do 1, 2, 3, 5, 7, whatever it is highly predictable that you would get a good result, because we cannot keep saying, Ueli, that we are so good, because this is not helping the others, okay? And they will just think that for them it will be like, how can we make it? So everybody has to strive to become every day better than it is.
Exactly.
But in general, I think our procedure, there is a certain part of the procedure that we can wrap down and somehow say, you know what, if you do, if you use this particular membrane, if you cut the flap with this release an incision, and so you will get predictably. It's a debate,
so I have to disagree.
It's okay.
No, I totally agree. Because if you work like we, I have more than 30 years working on this topic, and I made so many failures, and we all learn by failures. Mm-hmm. So I had the chance to do all these failures, and I must say that's how we learn.
Yes, please.
But on the other hand, we should, talking about young people, how we should train them, we should train them to take a lot of different aspects into consideration. And I'm a little bit against certain guidelines because they are too, let's say, primitive, If to say them, if you have a bone defect number 2, 3, 4, you have only 4 bone defects, this does not help. It's actually dangerous. Because a bone defect, then they are only judged in 2 dimensions. But as we know, it has 3 dimensions. You have to tell them biologically, look, where is the bone? For example, for an idiot, if there is a bone defect here, but it's space maintaining, that's much more important. Whether you have a bone defect 1, 2, 3, because that might be in the middle of the dentalous area, might be a bone defect number 3, but on both sides you have a nice bone. So yes, we should give all this knowledge away. We have to have some guidelines, but I think if we make it too simple, it's very dangerous. We have to give these young people, talking about immediate or late. Yeah.
But people here in the audience, people who are watching, they want to know when. What is the indication for immediate loading?
Right.
In what case can I do it?
Yeah, that's.
If I can say that now, immediacy, okay. Immediate loading and immediate implantation, you're not going to change the situation as it is, okay? So if you have to make it better, if you have to change anything, if you have to change the biotop, if you don't like the scallop of the tissue, if you don't like the color, whatever it is, this is a stage procedure, okay? On the contrary, if what you have is what you like, in my hands, let me say, immediate loading is very, and I would say, the most predictable approach to maintain the existing situation. Okay. Yeah. I don't know if I make the point.
So it depends on aesthetics a lot. I think
we are dealing in the most demanding area of the mouth.
Yeah.
But it's very interesting what Marco just said, because if you have a case where maybe the soft tissue is not perfect, then we come back to our patient. If he's actually happy with the situation, but it doesn't look great, and you can maintain this with immediate, so he had no papillas and he end up with no papilla and he's happy, hey, we have a happy patient, what else we want? It's a big success. On the other hand, if somebody shows up and he has still a papilla, but an infected papilla, so this is just swollen tissue, it looks like a papilla, and we know that whenever we start, he or me, whatever we do, the papilla will disappear. We have to find out whether the patient thinks it's still acceptable or not. And that has a big impact on our treatment plan, right? Because if you see that the soft tissue after tooth extraction will shrink anyway, but he's a very demanding regarding aesthetics, then you might say, well, this is not an immediate implant case. So this is, we have, the problem is that we actually have to understand what happens with the tissue once we start our treatment. On the other hand, we have to understand what are the demands of the patient.
Exactly.
And what Marco said, that with immediate implant, it might be easier to maintain what you have if you do it correct. We should not forget he has a lot of experience. We should not give the message to the unexperienced that immediate implant is something very simple. You agree? It's not simple. To find the right case, to do it right. But if we talk about the bone augmentation I showed today, I think if you don't have no experience, you better maintain what you have.
Okay.
So, because there are additional risks.
Yeah.
This is maybe a little bit more risky.
Yeah. Well, in the beginning of your presentation, I remember one word what occurred a lot, and that was time. Time.
Right.
Time. But also money. So the more time you take, the more expensive it is. But it looked beautiful.
Yeah.
So
not necessary. If we allow for healing a long time, that does not cost. If the patient goes away and comes back in 6 months, I don't charge these 6 months. It's fair enough. No. Let's say more treatment. More treatment costs more money.
Yeah.
Whenever we put our hands in a patient's mouth, we want money. What, you want money if you work?
Yeah.
But
Okay.
how do you know whether when it's necessary?
Well, this is experience, you know. It's necessary if the patient comes to me, he wants a perfect result, and I have to get rid, let's say, I have to get rid of a scar tissue. Before I start placing an implant, then I do a first graft only to get rid of, sometimes I could show you cases, tiny little scar tissue. And this costs already in Switzerland, costs a lot anyway, costs a lot of money, just to get rid of this little scar tissue. Is it worth? I have to discuss this with the patient. And I have to make my judgment. But then it costs money, that's right.
Yeah, exactly. So, what is the future outlook of this this trend to help patients in one day? What do you think? Is it a trend that patients that more and more patients in the world are being helped in one day with help of new methods, new technology, new material? Is that a trend, like I say?
There is absolutely a trend to do, let's say, shorter treatment, and I think I am very well known as the immediate loading guy worldwide. Okay, so everybody thinks I load everything instantly, but I want to come back. I can really show you thousands of immediate loading cases, but that doesn't mean that I treat all the cases in this way. So fast doesn't mean always better result, more predictable, less expensive. It is not correct. This is where the patient wants to drive us. This is what the industry wants to drive us. And I think we should not be driven by the patient, by the industry. You know, we know that in some cases, immediacy, faster is a great solution and is much better.
Yeah.
In other cases, it is something that I see the result. They are so poor and say, well, we did it in a day, so what?
Okay.
It looks like...
I understand, but is it a trend?
It's an interesting question.
Is it a trend or not?
Because we are Europe, we also always follow what they do in the States. In the States, it's a lot of pressure for the dentist to do immediate placement because everybody talks about immediate. And now the patients know, they come to the dentist and say, I want to be done everything in one day.
Yeah.
Now, if somebody is an expert and well known, like Marco, he might say to a patient, in your case, I'm not going to do it. The average dentist, if I may say so, he has a lot of pressure to do it, especially in the States. And it's incredible. Everybody places immediate implants, and they don't have the strength or the courage, or maybe also not the name to tell the patient, in your case, I'm not going to do it, it's not going to work.
Okay.
So this trend, I think, and most of you agree, if you look at what happens in the States, it's a very dangerous trend.
Okay.
It's pushed by the companies as well, but I think it's mainly pushed by a lot of dentists. They lecture on immediate everywhere, and if they show a lousy result, they still tell everybody, look how nice.
Yeah.
And yeah, for the average dentist, it's not easy, because if I'm lecturing in the States and I show what I do, is that we can't do this in the States anymore. My patient would not accept it, because the dentist left and right, he would do everything immediate.
Okay. So, what do you when you would be able to say to all patients in the world? What message would you have for them in order to prevent this demand for one-day treatments?
Well, we should, as a dentist, we should tell them, if a patient comes to me and wants to have it very simply done, I can do it, but it's not going to be perfect. What do you want? You know, we have to tell them what the options are. And there are cases maybe they're not at all for immediate, we would say we don't do it. But we have the right not to treat the patient. So we are still doctors, and we are responsible for what we're doing. So first of all, we have to tell the patients, as Marco said, some cases, if he does immediate, they might not be perfect, but it's good. Then tell me, listen, I can do it. It will look like this and this. You might have a compromise, but it will work. On the other hand, we should have the courage to say, no, I'm not going to place immediate implants. It is not possible to stand behind this treatment in your particular case.
Okay.
Yeah, I think the problem more often comes because maybe some colleagues refuse to do certain type of treatment, you know. And so I mean, many dentists in Italy and in Europe, they don't want to do immediate treatment because they are difficult, I think, or they require a lot of things.
So this will always be a tension between the clinicians and the patients.
No, I have no tension. I think we are in the position that we can do what we want. I mean, the patient come to see us, and they trust what we say. If you recommend immediacy, they will say, thank you, doctor. If you recommend augmentation, they should say exactly the same, because we want just the best for them.
Yeah.
But it's not easy for every dentist to, if the patient comes with a demand, knowing that both neighboring dentists would offer the patient this and say, no, I'm not doing it.
Okay.
At the very end, it's business.
Okay.
It's not easy.
Not so easy.
It's not easy.
Life is difficult.
That's the conclusion of this session about immediate placing. I would like to thank you so much, Ueli, Grunder, and Marco Degidi. Thank you so much for coming to the studio.
Thank you, Desiree.
Thank you for watching. And when you like this kind of conversations, please subscribe to our EAO YouTube channel and come to the conference next year.